Good day, dear students. I'm glad to see you all here. Today we will start the last section of first sem lectures, as you can see, infection and immunity. You already studied basic aspects. I will not talk about organs of immune system, lymphatics, and etc. as well, as I will not give you some clinical features, and it is the task of immunology department. I'm here to give you concept of immunity from the perspective of microbiology, interaction of microorganisms in our body, how our organisms can respond to infectious agent, and how to use main methods of immunology in diagnostics and prophylaxis of infectious diseases. So take your seats, let's start. First of all, I need to give you a few key definitions, the basic ideas of the topic. And one of the main is idea of infection itself. Primarily in medical practice, it is important to make a difference between two very close terms: infection and infectious disease. It is often confusing for you at the beginning of the discussion, but let's sort out. As you can see here, the difference is in one word only. That word is disease. So tell me please, how do you understand disease? How to describe disease shortly in few words? I'm pretty sure that a number of people will say that disease is some disorder bothering the man. And that is the key. Infectious disease is a disorder caused by microorganism or parasite. And an infection is an invasion of the body by a microorganism or parasite without any symptom. Of course, infectious disease is a direct consequence of previous infection. Without infection, infectious disease is impossible. But we can have infection without disease. How? Okay, let me ask you a few questions. If you was in contact with some ill person, for example, and that person coughed and infected you with some virus or bacteria, any disease, will you become ill in the same moment? The answer is no, of course. You all know very well that any disease have an incubation period when the subject is already infected but no symptoms are present yet. That is the stage of infection only, no disease. And of course it is a chance that if your immunity is good, it will protect you and you will not be ill at all. You even will never know that you were infected. But if infection will progress, infection will be transformed to infectious disease. Or another option, if immunity is strong enough not to allow infection to progress to a disease. But it's not so strong to remove microorganisms from the tissues completely. Microorganisms can remain in our body, in throat for example, or after the person will recover from some disease. And microorganism is not removed completely. It will remain in our body, in lichens, in tonsils, in some invaginations of mucous membranes. Why is it a problem? The problem is microorganisms will continue to multiply locally without any harm to the body. It cannot invade because immunity is strong enough to prevent that. And newly produced microorganisms, they cannot spread in the body. They will spread outside. And that person will infect every surrounding people, every surrounding man. That state is known as a carriage. Again, it is a phenomenon when microorganism colonizes tissues or locus of the body without causing a disease. Carriage. Those people are extremely difficult to find. They have no symptoms. They're not suffering from any disorder, but they are contagious. And we say that those people will act as a reservoir of infection. By reservoir, we mean any person, animal, plant, soil, water, any substance in which an infectious agent normally lives and multiplies. It is one more important key definition of the topic. Any person, animal, plant, soil, or any other substance in which an infectious agent normally lives and multiplies. Of course, you all know that a lot of microorganisms are living around us, but not every of them are able to cause a disease in human. And the ability of a microorganism to cause any kind of damage to the host animal is called pathogenicity. Again, ability of a microorganism to cause any kind of damage to the host animal is called pathogenicity. Thus, it will be better to say not a harmful microbe, but a pathogen. In medical practice, we rarely use the term microorganism. Sometimes we can say infectious agent, but more often and more correct word here is pathogen. As you can see, two terms very similar by meaning. Pathogenicity is the ability to cause a disease. So, as you can guess, pathogen is a microorganism capable of causing a disease. But the term pathogen is more comprehensive than just microbe, because not every disease is caused by microorganism. And it's more correct to say that a pathogen is any organism or any substance, especially a microorganism, capable of causing a disease. But I'm pretty sure you know and you can guess that not every microorganism can cause a disease in human. And you all know that we are naturally unsusceptible to a number of microbes. We have some animal or plant diseases absolutely harmless for us. According to that property, all microorganisms are classified or are divided into two major groups: pathogenic microbes and non-pathogenic. And common idea pathogenic is, we say, all or none characteristic. It means a microorganism is either pathogenic or non-pathogenic for given host animal. And that's all. Intermediate options are impossible. We cannot say that microorganism is a little pathogenic or it is a lot pathogenic. Pathogenicity is a property that cannot be measured. But of course, it's not quite right. And I think you guessed already that pathogenicity can depend on some factors. And write it down, please. Any microorganism that can be found in the host animal only in the case of the disease is known as obligate pathogen. It is not possible to have mutual relations with that microbe. That microbe cannot be a part of our normal flora. Any contact with obligate pathogen will lead to a disease. As an example, typhoid fever. We have potential pathogens, microorganisms which are normally non-pathogenic but can be harmful under certain circumstances. For example, damaged tissues or inoculations in body sites. Routinely, conversation here is about our normal flora, microflora of air and etc. While we have intact skin, no problem. But if you scratched, you will get an infection. And a rare group of pathogens is known as opportunistic pathogens. Opportunistic pathogens are microorganisms which can cause a disease only in immunocompromised hosts. That is the weakest group of pathogens. Even common concomitant diseases will not lead to infection with opportunistic pathogens. They are still too weak for us. Our immunity, even weakened, will be able to resist them. But when can they cause a disease then? For example, if you have very severe infection with HIV virus or suppression of immunity because of a cancer in the subject, then here you are. Cryptococcal meningitis is one of the most common opportunistic infections in HIV people. That group is also known as indicator for immunosuppression, because their presence in a subject will indicate that something is really wrong with immunity. Both groups, potential pathogens and opportunistic pathogens, can be frequently found as the part of our normal microflora, as we mentioned already. So, if any disease in a subject originates from our own flora or from its own flora, the disease is known as endogenous disease. But please don't tell me that endogenous is a disease inside us. Can we have a disease outside our body? Of course not. So endogenous from our flora. So why is it so that some pathogens are stronger, some causing more severe diseases and more number of people are affected? And why I said that pathogenicity is not completely all or none property. You already know that microorganisms are alive pathogens and they have some activity, can produce lytic enzymes to destroy our tissues. Other can have some extra organelles to resist our immunity. And different pathogens can have different opportunities to cause a disease. They're not the same by their powers. And of course, to describe and to understand how that particular pathogen is dangerous for us, we need to measure somehow their pathogenic properties. And if we need, we can, of course. So besides pathogenicity, we have virulence. And virulence describes the degree of the damage that a pathogen can cause to a host. A highly virulent organism is more contagious. It can give more severe symptoms or higher rate of poor outcomes. And that property, it can be measured. And that measure is lethal doses. I'm sure you all know what is LD50, LD90. Those measures are frequently used in the study of drug toxicity and some other side effects. And here it's exactly the same. So let me not stop on that, please. We will continue to next property. Invasiveness. How do you understand? What is invasion? If you ask any regular human, main number of people will talk about some alien invasion or some helminths invasion in doctors. Here the idea is absolutely the same. Invasiveness is the ability of a microorganism to penetrate through intact natural barriers, to invade tissues, to invade organs or some cavities, multiplying it and maybe inhibit immune protection of the host. So as you can see, invasiveness and virulence, two properties are going hand in hand, and both are responsible for pathogenicity of a microorganism given that property to microbe. So what factors can pathogen have to increase its virulence? First group of factors is factors of adhesion. It is regularly Pilia or Fimbria. Some bacteria have special system of surface proteins. All those systems required to help in colonization of mucosal sites, to adhere to human cells, and thereby a pathogen can resist coughing, sneezing, washing, blinking, and etc. In hospitalized people, it is important because those factors are crucial to survive on the surfaces of plastic. Catheters, tubes for artificial lung ventilation, some surrounding objects, and besides adherence, those factors are responsible for formation of biofilms. Few slides later, I will show you biofilm and we will talk what is it, but in common, it is a mucoid protective layer which is formed by microflora and can be formed by pathogens as well. It is helping to resist antiseptics, UV light, some physical and chemical factors, and etc. So factors of invasion, you should already know. It is a set of factors allow pathogen to invade the host. Mainly here we need to talk about some bactericidal proteins with enzymatic activity. Protease, hyaluronidase, neuraminidase, elastase, collagenase, and any other enzyme you will know with lytic activity. Those factors are required to destroy intact barriers of our tissues, and pathogen can easily pass through skin, for example, and facilitate local tissue spread. We have IgA-specific proteases. It is a set of enzymes produced by some bacteria which can cleave and inactivate secreted IgA on our mucous surfaces. and prevent an activation of a pathogen by that antibody. So we should not forget, of course, about hemolytic enzymes. Mainly hemolysis is destruction of RBCs, but actually those enzymes are active against white blood cells as well. They can lead to suppression of local inflammatory and immune response. They make an invasion easier for microorganisms. So capsules. I really hope that you still remember what is capsule. It is an organelle providing protection against phagocytosis and opsonization. Again, it is the topic of next lecture, so we will discuss later. But those factors help bacteria to avoid killing by immune cells. Toxins. It is very important virulence factor, but it is too important just to mention it here. So in a few more slides, I will describe toxins in detailed manner. Siderophores. It is a group of iron-binding factors that allow some bacteria to compete for iron with the host. It should bind to hemoglobin, transferrin, lactoferrin, but those enzymes will lead to insufficiency of those compounds in our body, leading to some clinical features. The last, but of course not the less important group, it is a multiple factors providing resistance against antibiotics against our therapy. Again, that group of mechanisms we already described in previous lectures. We can give here some beta-lactamases, different plasmids. So again, it is the topic of genetic and antimicrobial resistant lecture. So as we said, toxins. Toxins are very important factors. Toxins are classified into two important groups, endotoxins and exotoxins. Endotoxins are lipopolysaccharide, complex with the protein. It is a natural compound of the cell wall of bacteria. Routinely, they are weakly immunogenic and rarely fatal, leading to some non-specific inflammatory process. Action of endotoxin is realized by activation of our own immune cells, which produce an endogenous inflammatory mediators. Two important things we need to emphasize here. First one, endotoxin is not produced specifically. It is a natural compound of the cell wall of a pathogen. So it's just present in the cell. It's not produced, secreted, or something like that. And it is released outside when cell is destroyed. Toxic molecules will start their effect. Second thing, even if structure of endotoxin can be different, regardless of that, any type of endotoxin will give the same effect, a release of our own inflammatory mediators, which are non-specific. And of course, symptoms will be related to effect of our own mediators. Systemic fever, headache, nausea, vomiting, any symptom of some common disorder you can name here. So by clinical features, it's not possible to identify which particular type of toxin you have here. Symptoms are always the same. And of course, we don't have some targeted therapy against endotoxins. The main task for a doctor is to control our own inflammatory response. And it's not required to identify a particular endotoxin which is present in current case, because management of the subject is the same. And in common medical practice, we say just endotoxin. We unify all endotoxins in one single. Sometimes we say LPS, lipopolysaccharide. That's all. If you remember the structure of bacterial cell and main difference between gram-positive and gram-negative bacteria, you will guess that LPS is prevalent in gram-negatives because gram-positives have peptidoglycan as the main compound of the cell wall. And actually, the most potent and the most toxic LPS and present in Enterobacteria you will study next semester. So we stress the key properties of endotoxin, and now we need to point out key properties of exotoxins. And I really hope that you are smart students, and for sure you can grasp that if names of toxins are opposite, their properties should be opposite as well. So let's turn over. endotoxin is a structural compound of the pathogen which is naturally present as the part of the cell. Then exotoxin is non-structural. If endotoxin has no task to harm our body, it's just produced by the cell, then exotoxin, of course, is toxic and produced to harm our body. If endotoxin is released after cell is dead, exotoxin is secreted outside while pathogen is alive. If any endotoxin will cause the same effect, then exotoxins will lead to unique effects. And if we have no treatment against endotoxin, we should target it. We should have targeted therapy against exotoxins as well. What else should we point here? Exotoxins are lipopolysaccharides, and proteins. Exotoxins are proteins. It is the chemical nature. And as a consequence of that, exotoxins are pretty sensitive to heat. Mainly they are heat labile, while endotoxins are heat stable. LPS is stable to heat. So exotoxins can be produced by a number of bacteria, but most commonly gram-positives. Although some gram-negatives can do it as well. So any bacterium capable for production of exotoxin is known as toxigenic. And ability of a microorganism to produce a toxin is known as toxigenicity. Toxigenic bacteria are pretty frequent in medical practice, and exotoxins are very different in the strength of the effect and the clinical features of the effect, and they can vary from mild disorders to even lethal consequences. Regardless of the strength and despite the effect, all exotoxins have very close structure. Again, it is a 3D model, and even if exotoxins can be have common structure, their minute structure is pretty different. So it is a model, 3D model of exotoxin. It have lower part and higher part, and as you can see, lower part is made of 5 identical B subunits. That is the classic structure of AB toxin. So during study of toxins activity, it was shown that lower part is responsible for recognition of a specific type of a receptor on the surface of the cell. And when susceptible cell on the host organism is found, B subunit will bind to the surface and fix the toxin. Thus that subunit was named B. B is binding subunit. So that principle, the idea of effect of exotoxin, is similar to virus. Due to the limited size, one toxin can recognize only certain receptors. Routinely, one tissue is affected by exotoxins only. And according to which tissue is affected, we can have neurotoxin, cardiotoxin, enterotoxin, respiratory toxin, some cytotoxin, and etc. Of course, exotoxins differs one from each other, not only by tissue, but by mechanism of the damage as well. And as you can guess, A subunit is responsible for that. It is active. A is due to activity. A subunit is made of 2 parts, smaller A2 and bigger A1. A2 mainly performs transport function. It delivers A subunit, A1 subunit into the cell. A1 is enzymatically active, and when transferred to cytosol, it can inactivate ribosomes, block influence, or some enzymes. It can perform some function to disrupt activity of the host cell. And due to the very potent effect and specific structure of exotoxins, they are highly immunogenic, highly toxic, and very often they are fatal in micrograms quantities. You will not even see that amount of exotoxin which is able to kill you, and it is the most potent virulence factor found in bacteria. But of course, not only due to exotoxin production, microorganisms can be harmful for us, and we need to know how each and every microorganism is dangerous for us. Why? To understand how to handle microorganism in lab in your practical classes. And according to threat which is posed by a microorganism for individual person or for the community, all microbes are classified into, we said, risk groups. We have several classifications, but the most accepted worldwide is the classification of WHO or World Health Organization. WHO defines risk groups as following. Risk group number 1 includes microorganisms that are unlikely to cause disease in healthy human or in healthy animal. Regularly we're talking about yeast, Lactobacilli, and some microbes naturally found in surrounding us facilities and surrounding media. Risk group number 2 includes pathogens that can cause human or animal disease but are unlikely to be a serious hazard for laboratory workers or for the community and environment. If you will have any type of laboratory exposure, it can cause serious and severe infection. But against those pathogens, we should have effective treatment, effective prevention, and risk of spread in community is very low. In that group, we can give streptococci or herpes virus as an example. So group number 3 includes pathogens that usually causes serious infection in human or in animal, but does not ordinarily spread from one infected individual to another. And as well, effective measures of prevention and therapy should be available. And here the most known pathogen is Yersinia pestis, which is causing plague. In viral infection, it is HIV virus, for example. So risk group number 4, of course, is the most strong. It is a pathogen which causing serious human or animal infections and can be readily transmitted from one individual to another individual, directly or indirectly. Effective treatment and prevention are not usually available, or access to those measures is limited. And here we can talk about some Ebola virus is one of the latest examples. That part, of course, is slightly boring, and as usual, I can hear your favorite question. Let's think. In that time, your task is just to know all possible features of all microorganisms. In next semester, you will study particular features of exact microorganism. And it is important to know complete list of virulence factors of every microbe and their powers, because you are going to be a medical doctor. And what a medical doctor needs to do? Correct. Diagnose, give a therapy, and prevent complication. And of course, you should do it as soon as possible. And of course, identification of every virulence factor requires time and certain opportunities of laboratory. And it is possible that you can have no time, or you will have no test available in your lab to identify every factor of a pathogen obtained from your patient. And in that manner, to be a good doctor, you should know by heart the whole set of virulence factor of every pathogen. And when your lab doctor will identify only the species of the pathogen, you remember the species, yes, it is the medical name of a microbe. When lab doctor will give you a species, you will already know what virulence factor can be found in that microbe. You will know what to do to save your patient. And of course, you remember main goals to study microbiology. You should not only keep your patient safe, you should watch yourself and remain healthy. And of course, even now you understand that disease caused by first two groups are pretty safe for you as well as for surroundings. I mean fourth and third group. And of course, you can treat patient in common facilities. You can perform lab diagnosis with common features, common rules. But what if you suspect plague, or you think that it is anthrax or Ebola? Of course, it's not safe to keep a person in open area, And of course, you cannot examine the patient without proper safety measures. And now we are discussing lab diagnosis. And in laboratory, workers can be exposed to the pathogens as well. We have that problem. And according to risk group of a pathogen, we have corresponding rules of a lab behavior. How to handle the sample containing pathogen in lab, and corresponding requirements to lab equipment. So another authority, it is a Center for CDC, Center for Disease Control and Prevention. CDC classified all laboratories in 4 categories according to the risk group of a pathogen that particular lab can handle. We call it biosafety level. Biosafety level 1 implies work with the first group of pathogens. Access to the lab is free. Any worker can enter. Territory is open. Open lab tables, open benches. Personal protective equipment is optional. Gloves and masks are worn as needed. Biosafety level 2 requires biological safety room with self-closing doors, laminal floor hoods or laminal floor units, and access to laboratory is routinely restricted when work is being conducted only. And in that type of laboratory, gloves are required. All procedures here are done in that laminar flow unit. It is a closed cabinet, protective glass to keep your face safe and not to inhale contaminated aerosols and not to inhale toxic aerosols. Some free areas available to put your hands to load samples, and that unit performing air circulation with multiple different filters, UV sterilization. Air is taken from room, sterilized, and turned back into the same room. But it is pretty safe to breathe with it. Biosafety level 3, you could see that maybe you saw it in some thrillers. 2 sets of self-closing and locking doors, not to enter in the lab directly. You enter in the first zone, door behind you is closed, air is removed, sterilized, door in front of you is open, you enter in the lab. And it's required to prevent exchange of air between lab and the corridor. Access to the lab is restricted and controlled at all the times. And authorization card is required, or some codes, personal identification system maybe is working. And that lab should be split into zones. Clean zone, to use some computer, perform common duties, maybe write down something, and dirty zone, where all job is performed. So sustained directional airflow in dirty zone is provided from clean areas, not in the same room. And after use, it is removed out. No air recirculation. Gloves, personal inhalers are required, maybe some protective suits of open types, non-hermetic. Because of high virulence properties of pathogen in the lab, medical surveillance and regular immunization of the staff is required. Vaccination against that particular pathogen is obligate to prevent any accidental infection of workers. In that type of lab, we can use specific type of laminar flow units. They are closed, no open space. You see that door is locked, you have sleeves to put your hands, you will not have direct contact with the pathogen. You can put a sample in that area, close the door, air will be exchanged, you will put a hand in the lower zone and perform any duties without any contact of sample with your air or your skin. So the last type is 4th type of biosafety level laboratory, restricted type. Maybe you saw it in some zombie apocalypse movies. More often it is separate building and the whole building is secured. Can be secured with armed troops. Access is restricted by several identifications levels. Building is split into restricted zones. No windows, thick explosion-proof doors, separate zones to change clothes, separate zone to put your individual protective suit, with independent personal air supply. Shower upon exiting, decontamination of all material. I am pretty sure you saw it in some movies when the person is treated with chemicals or some shower before entering. And that is the most strict type of lab. Of course, in our lab, in our teaching lab, we have only biosafety level 1 equipment. So when you will attend classes, the only thing we ask is a lab coat, lab cap, and clean second shoes. No respirators we ask, no gloves, only if you like, if you want. So just common measures because first type. We have second level lab in our university, but it's not for students. Students are not allowed here. So some examples of laboratory you can perform. As you know, not only laboratories have that classification. We have the same approach in hospitals. We have common wards. When several patients with common disorders are hospitalized together, regimen is free. People can have walks outside, relatives can visit, and it is fine. We have boxed wards. In infectious hospitals, mainly when single or few patients with the same infectious disease are put in a separate room to prevent infection of others. Air is common with environment, but ward is closed, no walk, access is limited, and if you want to have contact with healthy person, it is possible only through protective glass. You can put something, talk, but no direct contact. And isolate wards, mainly in hospitals of highly infectious diseases. It is a closed ward, separate autonomic air circulation, sterilization, restricted access, and measures of infectious control at all levels. So, of course, if you as a doctor will see some common disease in your patient, you can continue here. You can put it in common hospitals, take samples in routine manner, and send to a regular lab. But if you suspect any dangerous disease, you should transfer your subject into appropriate type of hospital. Minimal contact. Diagnosis should be done near the bed of the subject. And now I have a question for you. Why to transfer a subject? Why so strict measures in lab? Why different types of wards? Of course, mainly we'll talk that it is a measure to avoid infection with the pathogen from patient to patient in the hospital or specimen to lab doctor. And more viral pathogens require more strict measures to avoid infection of surroundings. And now the key question is, how is it possible? How infection from one object can be delivered to another object? It is me who should answer that question, and mainly infectious disease, in the contrast with somatic diseases, have transmission. It's not appear from somewhere. That transmission can occur in different ways. For sure, you already know some, but as often in the case, we have a system here. And any transmission occurs through contact of healthy individual with the infected individual. We name as a direct contact transmission. When one person touching directly another person. Direct contact can occur in two ways, vertical and horizontal transmission. So horizontal means you have a mass of people and they're living right now right here, and transmission occurs amongst those people from here, here. They go in horizontal way. That means horizontal. Vertical transmission, it is from current population, that mass, to future one. For example, mother to newborn baby. Of course, we all remember that mother and fetus have common blood circulation, and main substances from mother can be shared with the kid, including some pathogens. So horizontal transmission can occur in several types, and it is split into person to person. If it is a physical contact between two individual persons, handshaking, for example. Any type of sexual intercourse will be named as a sexual transmission. So we have direct droplet way. It is when a person coughs or sneezes, small droplets of mucus that may contain pathogens are injected, and the pathogen is transmitted directly to a new host, routinely over a small distance, 1 meter or less. And that happens immediately after coughing or sneezing. And if we have any mediator, an additional member in the chain to transmit an infection between individuals, it is indirect transmission. Indirect transmission, indirect contact transmission, involves inanimate objects or fomites that becomes contaminated by a pathogen from an infected person or reservoir, such as door hands, for example, or non-sterile medical equipment or some others. We have vehicle transmission, which refers to a transmission of a pathogen through water contamination because of poor sanitation, through poor handling or storage of improper cooking procedures of the food products, or inhalation of dust and fine particles known as aerosols, which can float in the air, can carry pathogens. So here I need to pause. As you could notice, we have two ways of transmission by air. Droplet transmission, it is over short distances. Direct contact in two closely standing men like here. And longer distance for that person is considered vehicle transmission. Larger particles will quickly drop out of the air, and fine mucus droplets can remain suspended for a long period of the time. They can merge with the dust particles and travel considerable distance, like here, for example. So it is a vehicle transmission. Too close, small distance, directly now. One way and large distance, vehicle transmission. So we have vector transmission. Mechanical vector is an animal or insect that only carries a pathogen from one host to another without being infected itself. Fly may land on the fecal matter and later transmit bacteria to food, or if it lands on, but fly itself is not affected. Biological vector transmission occurs when a pathogen reproduces within a biological vector that transmit the pathogen from one host to another. And here mainly we're talking about arthropods. They are the main vectors responsible for biological transmission: mosquitoes, ticks, and etc. Due to the epidemiological and medical importance, we have very significant group of infections named nosocomial. Nosocomial infection is any infection acquired in healthcare facilities, including hospitals. They're often related to some surgery, invasive procedures, and any way that provide the pathogen with an access to the portal of an infection. Pathogens adapted for severe and aggressive hospital conditions are much more aggressive in virulence. They're resistant to physical factors. They're resistant to chemical factors due to frequent contact with them, and due to massive use of antibiotics, of drugs in hospitals. Nosocomial pathogens can tolerate main number of antibiotics and become resistant. Nosocomial infections are associated with higher rate of lethal outcomes. And by analog, infections acquired out of medical facilities are known as community acquired. Regularly community acquired infections are mild in duration with more favorable outcomes, and they are routinely easier to treat. So after a person became infected with the pathogen, infectious disease can occur. Seems like obvious. But actually infectious disease can be of different types because of different origin. Again, we have some differences with somatic diseases here, which are important to understand. If we're talking about first episode of a single disease caused by a single microorganism, routinely we say primary infection. You was healthy, today you've got common cold by some influenza virus. It is primary infection. If you will recover without any complication, of course, no one will use the term primary. People will just say infection. You can be provided with some diagnosis, respiratory infection, and that's all. So when to use primary? When infection is not alone, for example, it can be relapse. Relapse is a second episode of the same infection with the same strain of microorganism. Usually it is happen when the first episode was not treated completely or it was undertreated. And primary infection can lead to relapse. Reinfection is the second episode of the same infection but with another pathogen. After primary influenza disease, your immunity weakened and you've got the same disease with the same symptoms, but now pathogen is the bacteria, Haemophilus influenza, for example. So secondary infection, an infection in one organ or one system on the background of the primary infection in another organ or system. The classic example here is HIV infection. HIV is acting as primary infection. It's affecting the immune system. Weakened immunity allows fungi to cause pneumonia. Pneumocystic pneumonia, for example. Lungs are affected on the background of infection in immune system. And HIV is primary infection, that pneumonia is secondary infection. We have term of superinfection. Superinfection is the type of secondary infection, but on the background of the same infection of the same organ, but caused by another organism. Frequent example here is hepatitis. You will study next time, but maybe you already know we have multiple types of viral hepatitis, A, B, C, D, and etc. So parenteral hepatitis usually are blood transmitted, and drug abusers are in the main risk. And if any person is already infected with hepatitis B, and today that person shares a syringe with a hepatitis D person, our poor guy will have superinfection. Viral infection of the liver will join viral infection of the liver. The same disease in the same organ, but pathogen is different. That is superinfection. The last type is co-infection. Co-infection is simultaneous infection of one organ or system by multiple pathogens at the same time. For example, sexually transmitted diseases, STDs. If any person has venereal syphilis and gonorrhea at the same time, and that person having unprotected sexual intercourse with the healthy person, both diseases of the sexual tract will be transmitted to a healthy person at the same time. One organ, different pathogens, co-infection. By default, we will discuss clinical and microbiological features of primary infection, of course. And any primary infection has common clinical features, common trend or common progress. Almost always we can identify main stages of that progress. And you know already that it is incubation period, prodromal period, acute period, and convalescence period. And do you remember the diagram? I showed it to you, should be in the first lecture. Can you tell me please why it is here? I said before, medicine is a multidisciplinary science, and microbiology is only one of these disciplines. And of course we need to know all. It is a graph of bacterial growth we said that after inoculation on a nutrient medium, microorganisms will undergo several stages: adaptation to new conditions, exponential growth, log phase, fight for resources, stationary phase, and death. And you asked first lecture, why do we need that? And now I'm giving you an answer. It is the key to clinical stages of any disease. Lag phase and incubation period. It is the period between exposure to a pathogen and first symptoms appeared. Microorganisms here adapting. It's growing only locally to reach some mass, some population which is required to produce symptoms in the host, to invade the host. And then you have log phase. It is a prodrome period, the time of non-specific symptoms such as fatigue, malaise, nausea, and some again others. That period observed between end of incubation period and the point when unique characteristic symptoms of the illness will appear. So symptoms of the prodrome are common for any disease. They just a reflection of our immune response activation to stop rapid multiplication of a pathogen. And of course, if symptoms are common, it's not possible to identify the pathogen which causes the disease by clinical features yet, because acute period is a peak of exponential growth in population of a pathogen. And in that period, stationary phase, symptoms are very pronounced due to the strong response of the immune system. Microorganisms need to fight one with each other for resources. They fight in with competitive overgrowth population and with immunity. And in that stage, microbes will release all virulence factors available. And symptoms will appear specific to organ affected or by system. And by set of history, symptoms, and some clinical features, you can identify or at least suspect particular pathogen. So convalescence period, it is the time when host recovers and returns to a baseline, and the pathogen load declines, infection is cleared, all symptoms are gone, or the pathogen can appear stronger. The subject can die, but the body, of course, cool down, and our mesophilic pathogen will die with the patient. And we talk about persistence, where number of microbe is fluctuating. Dead cells will give nutrients for live cells, ingredients, reproduction, new cell appear, again dead, but average number is the same approx. And what is it in medicine? We talk today, of course, it is a carriage. It is some balance between strength of our immunity and power of the pathogen. It's the concept. Of course, symptoms of a main period and duration of every period vary in different infections. But common concept is that. And I think we will finish the part of the lecture which is related to microorganism with that slide. So now we need to talk about microorganisms, means us. Keep moving.